introduced myself to the patient and told her the process of the IV. And I always explain to somebody that I'm going to stick you with the needle. We're going to take the needle back out, and you're going to have a flexible piece of plastic. If you have a kid, you tell them it's like a sippy box that you're going to put the needle in the sippy box like that, and then he has a straw that we can give him to drink in his arm. It's kind of a way to describe things. So I'm looking to see a couple of different reasons why we need the IV. In this case, we're going to go with what we know, which is in the emergency room. We almost always use the AC because it's the biggest, quickest to access. And also, a lot of times we're doing tests where we have to do a lot of medication administration, contrast administration, and you need it as close to the heart as you can get. You also need a bigger size catheter. One other thing is, that's also another choice, and also practice on where you're working, what size catheter you use, what gauge. Just remember, though, the tubing on this pigtail is 22 gauges. So no matter if you put a 14 gauge in her arm, if you attach this, you're only going to get it going as fast as a 22 gauge. So if you ever have to get fluids in quickly, you just attach it to the hub of a bigger catheter.
And a lot of times they'll have stuff, they have what's called trauma tubing, which is an actual bigger gauge. I think it's either 14 or 16 gauge
big.
tubing. It's really big. So if you really need to give somebody fluid fast, you can get that kind of tubing.
I didn't know that until I'd been a nurse for a good 10 years.
Yeah, somebody told me that like a year ago.
Okay, so I'm going to put the tourniquet over her gown so I don't pinch her skin. And I actually don't, I don't measure whether I've cut off her circulation or not, because I kind of do want to cut off her circulation. I put it on, I punch her in the boob, and then I twist this around. And then I think I showed everybody. You guys all were very good with putting the tourniquets on. Sometimes that's the hardest part. And then I'm just going to take a look for a second. If she was hard to find veins, I would lower her arm, like gravity hang, let her arm hang over the side. Usually you want to have your patient laying down for this, just because they may get queasy and nauseated as you're doing it. She's got a huge AC right here. And if I couldn't feel it really well, or she's got one over here, if I was thinking that she's going to be in the hospital a long time, I might use this little one here so she could bend her elbow. But because I'm nice, I'm not going to make one that hurts. We're going to go right here. And it's a nice big AC, and you can feel it's round, firm, and elastic, right? I always think it feels like a rubber band. If you feel that, if it feels kind of bouncy and hard, but it doesn't feel like it mushes in and bounces back, that's probably a tendon. And there's lots of them in most places we put IVs, okay? So this one looks really good. That's where we're going to go. And pop the rubber band off so I don't make her fingers numb. If she was really hard, I might actually leave the tourniquet on, just to keep the vein juicy and tell her fingers are going to go numb. Okay, so I've taken the tourniquet back off. I'm going to put my gloves on now. And the one thing you want to make sure you do is that you feel the same spot with your gloves on that you felt without your gloves on, because your fingers feel different with gloves and without. Your sensations muted and changed.
You may see some nurses pop off a finger on their gloves. Don't do that. Do not pick up that habit.
Okay, so I've got all my stuff here. I've got my tape nearby. All right, everything's ready to go. So I'm going to put the tourniquet back on. I'm going to feel once again. And I'm also feeling kind of the angle in which this goes. I know some of you are asking me how you feel. You want to go to the lowest portion that you can sense, you can feel, and then you also want to go above and follow the vein so you know which angle to go. So her vein kind of curves a little to the lateral aspect, so I'm going to kind of angle that direction rather than just straight up. Okay? At this point, I've taken this out, I've pinched it, I've already primed this. I'm going to set it down right here, shake it a little bit, and then I'm going to clean for 30 seconds. And see, as this gets wet and as I'm looking at it, you'll see that it'll kind of stand up a little cleaner, or you'll see the vein a little better when it's wet and when you're rubbing it. Okay, that's 30 seconds. And then a lot of times, I didn't even explain it. A lot of times I'll clean my fingers so that if I have to touch, once I've cleaned her skin, then my finger's as clean as it can be. And I know, did I do it different? Because I think it says clean it and then get all your supplies together.
Place the connective prime nearby, reapply the tourniquet,
Okay.
and check for distal pulse. And then this is to anchor the vein
A little bit.
distal end.
Right. If you had somebody Mary's nice and young, so she's got nice firm skin. But if you had somebody who had kind of wrinkly skin, you can pull down, and this is what it means by anchoring. When you hear people talk about their veins rolling, it's just because there's loose skin on top of the vein, and it'll move as you push it with the needle. So if I thought this needed anchoring, which I probably do anyway, is just hold it tight like this. Okay? Some people say to do it above. I think that's a dangerous way to do it because if the patient jumps, you're going to stick yourself in the thumb. Okay? Alright, so now I'm going to take my catheter out. I'm going to gently loosen the little hub there. Okay? Level up.
You can't watch.
You can't watch it. Okay.
I can do that.
And I'm going to actually, see, I already anchor. I don't always remember the steps I do. Anchor here. My finger's up. I'm resting my ring finger and pinky down here. On the count of 3, you're going to feel a big stick. 1, 2, 3. Ouch, 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 ouch. See the flash came back? That's the blood going in. Now I'm going to just slightly advance, like 1 millimeter to 0.5 millimeter in, so I'm in the vein. And then I'm going to push the catheter down and in. Okay? At this point is when I pop the rubber band off. Okay? I'm going to push down a good further than 1 inch. I'm going to push down hard. I'm going to track that and see, even though I'm pushing down, she's nice and healthy, so she's going to bleed, which is okay. Everybody all right? Nobody's passing out on me? All right. You can always clean up a mess, but if you worry about the mess more than getting the needle in, you're going to have a harder time. Okay, so now I've put that in. It's all the way to the hub, right? I'm going to withdraw a little bit, make sure it's in the vein. See how the blood comes back? And I'm going to just gently push. And it flushes, and what I'm looking for is to see that there's not an infiltration, which would be 1 inch above where the catheter is, and it would swell up. Is that hurting at all? No?
Nope.
Okay. And it says to pull back and flush a couple more times. Now, because I made a little bit of a mess, I need my 2x2s before I put the tegaderm on. And at this point, you usually just gently push and try to hold it still rather than rub it around too much because you'll pull the IV out. If there's a little bit of blood underneath the tegaderm, that's okay. But you don't want to have it a big puddle of blood underneath there. Alright, and the rest you can clean up afterwards. What I do here is I'm used to doing this kind of with my hand, so I hold the catheter and pull that open. The bevel part goes down, set it right across, and then what I do is I pinch right over the hub of the needle to make sure that part is stuck. The rest can just be wherever. Okay? You're going to take this part off. If you pat it as you're pulling it off, it'll keep the edges on the skin. I'm going to set that to the side for when I need it. This you can use to get it wet. Alcohol actually works better than the chlorhexidine to clean up blood. But and this is one of the reasons why you don't take your gloves off sometimes before you tape it down, because you may need to do a little bit of cleaning, or let's say she dislodged it because she freaked out. While I'm doing this, I'll need gloves on to stop the bleeding. Okay. So, you take the bloody glove off though so I don't make a bigger mess. My 2 pieces of tape. And even though this is hard and the tape sticks to your glove worse, it's much better than having it lay flat on a dirty table. First one you put through is the U, which is going to go underneath, and then I usually take it on both thumbs under and flip it over the wings. This is going to hold the IV in place so that it doesn't pull out this direction, down distally. Okay? The second one I usually put across the top here, and this is going to keep it from moving from side to side. Depending on how hairy the patient is, how sweaty they are, things like that will determine how you tape it. I'm going to flush again one more time, and then as I'm flushing, see I pinch this as I'm flushing, and that will keep the pressure of the saline down there and keep the vein open. One last piece of tape because I want to keep this tubing as flat against her skin so that she doesn't pull through with her thumb, but also to keep the end piece available should I need to hook anything up or give her medicine. You don't want this flush hard against the skin, so you have to untape it every time you have to give her a medicine. So then I just go right across the same tape I've used so I don't pull more skin off, and then she's all set. And I usually tell people, now you can bend your arm, you'll feel the tape pinch, but it's not going to poke through anything. Okay? Yeah, last part I have to do